We're on time and we're moving on to our next speaker. And it's my pleasure to introduce João Carreira. João Carreira is a senior clinical vascular scientist at Manchester Academic Vascular Research and Innovation Centre. And he's also a team leader at IVS Limited. Over the last 7 years, João has been part of research team with a special focus interest in developing 3D and contrast-enhanced ultrasound imaging methods. And he's here to present some of his work today, looking at detection of endoleaks after EVAR. Thank you very much, João.
Thank you, Adrian, and thank you, Bracco, for this invitation. This is just a pre-introduction to my talk because I have already recorded it, so I hope everyone enjoy it. Thank you. Good evening all. My name is João Carreira and I am a clinical vascular scientist working in Manchester. Over the last 7 years, I have been working with contrast enhancement ultrasound in the vascular field in a number of scan modalities. And today, this presentation is about endoleak detection in EVAR using contrast. NICE guidelines recommend open surgical repair to patients with unruptured abdominal aortic aneurysm, unless contraindicated by abdominal computology, anesthetic risks, or medical comorbidities. And only in these cases, an endovascular abdominal repair should be considered. The reason for this is although EVARs have potentially low perioperative morbidity and mortality rate and short hospital stay, recent studies have shown that the early survival benefit of EVAR decreases or is lost over time when compared with open repairs, as EVARs carry a higher risk of complications such as dislocation, stenosis, infection, with the most common being endoleaks. And therefore, long-term follow-up in these patients is needed to detect early device-related complications and allow reintervention before a rupture occurs. So endoleak is a persistence of perigraft blood flow within the excluded aneurysm sac, a complication that, if not treated, can potentially lead to an aneurysm enlargement and rupture. There are 5 types of endoleaks. Type 1 endoleak, subdivided into type 1A, proximal attachment leak, or a type 1B, distal attachment leak. Type 2 endoleak, defined by blood leaking into the aneurysm sac from an aortic branch, which again can be subdivided into type 2A with 1 entrance but no exit identified, or type 2B with 1 entrance and 1 exit identified. Type 3 endoleak, defined by blood leaking through a defect in the endograft itself, such as a fabric tear or a graft dislocation or a graft disconnection. Type 4 endoleak, referring to blood leaking through the pores of the stent graft, although this is rare in the new generation of EVARs. And last, type 5 endoleak, continued remnant sac expansion without evidence of a leak site, which sometimes can be due to an intermittent leak that is not seen on imaging. Some of these endoleaks are more dangerous than others and require repair. There is a high risk of rupture, like in type 1, type 3, and type 2 endoleak with sac expansion. Some of them can just be treated conservatively, like type 2 with no sac expansion. So with EVAR needing long-term follow-up, NICE guidelines recommends enroll patients into a surveillance imaging program based on duplex ultrasound, CT angiography, and contrast enhancement ultrasound. However, duplex ultrasound alone is not sensitive enough for endoleak detection, and the fact that CTA is expensive, involves radiation, and its repetitive use causes cumulative renal damage by nephrotoxic iodinated contrast media, raise several major concerns for lifelong surveillance. So contrast comes as a good alternative imaging for endoleak detection and classification, with several studies mentioning its high sensitivity and specificity using CTA as a gold standard. And furthermore, contrast is a safe imaging modality without the use of radiation or contrast-associated risks, is non-invasive and cost-effective. In our trust, we use SonoView. We order SonoView from the pharmacy and use the scan referral by the doctor as a prescription. As a clinical vascular scientist, we undertake hospital courses such as cannulation, adult IV therapy, ANTT, acute illness management, and adult resuscitation. For cannulation and SonoView administration, we use a peripheral cannula size 20. Anything below that might have the risk of contrast distractions before entering the bloodstream. There is a total limit of 5 ml SonoView that we can administer. And after the scan, patient waits for approximately 30 minutes in the waiting area for a side reaction monitoring, although they are rare, and in the 7 years I have never experienced one. After the cannula removed, FIP score is recorded to the scan report, and as well as the SonoView batch number and date. These are some contraindications to SonoView administration, and the doctor and the sonographer should take them in consideration when requesting and performing a scan. So total contrast scan assessment should take approximately 30 to 45 minutes. Using a curvilinear probe and changing the settings to a contrast scan in the ultrasound machine, which automatically should lower the mechanical index as to not distract the contrast bubbles. Quite often, 1 ml SonoView followed by 5 ml saline flush is enough for a diagnose, but if necessary, a total 5 ml SonoView can be administered. Flash mode option or IPRF, depending on the ultrasound machine, is a useful option as to determine endoleak source. So when doing a contrast scan, it's always good to have a first approach of the EVAR in transverse section and longitudinal section, as endoleak sites can easily be picked up in these views. The destruction of microbubbles can be useful to determine the type of endoleak by the time it takes for the contrast to re-enter the leak and the limbs. So in this case, we can exclude the presence of a type 2 endoleak as no contrast outside of the limbs is seen. And in this other video, using the flash mode option, we can see the time delay it takes for the contrast to re-enter the leak in the posterior aspect of the sac and diagnose a type 2 endoleak. A common criticism of 2D ultrasound is that it's operator dependent, requiring the operator to interpret 2D image into 3D, and this may make interpretation of difficult scans challenging. So the use of a 3D ultrasound system with the aid of contrast allows a volumetric 3D image reconstruction that can be manipulated and interpreted in any plane by vascular specialists, so allowing for a more detailed interrogation of the ultrasound data and a more accurate diagnosis. In this study, 3D contrast was more sensitive than CTA for endoleak detection after EVAR and more accurate in its classification using the MDT as a reference standard. Another potential use of 3D contrast or contrast enhancement tomographic ultrasound, it's in EVAR patients with contrast allergy and severe chronic kidney disease. So with carbon dioxide angiography used for EVAR deployment, but lacking adequate sensitivity for completion imaging, 3D contrast may have a specific role in completion imaging in an iodinated contrast reduction strategy. So previous studies have reported that more endoleaks were accurately detected and classified as opposed to rotational angiography in completion imaging following EVAR. So this is a video of a volumetric 3D image that is being manipulated from different angles. And as you can see, both EVAR limbs and at the path of what is a type 2 endoleak. So in this last part of the presentation, I will show you cine loops of different types of endoleaks. So in this first cine loop, a transverse view reveals that aneurysm sac is not fully excluded, and contrast is seen in the proximal attachment outside of the limbs. In this second cine loop, a flash mode option reveals no time delay in contrast appearing in the sac compared to contrast appearing in the limbs, suggestive of a type 1A endoleak. In this transverse view, again, we can see contrast outside of the limbs, but this time in the distal attachment. And flash mode option reveals no time delay in contrast appearing in the sac, so suggestive of a type 1B endoleak. So now we have a transverse view demonstrating contrast localized in the posterior aspect of the sac. And flash mode, and the slight time delay is seen, as well as the entrance site of the endoleak. So in this case, no exit is identified, and continuous growth of the aneurysm sac is suggestive of a type 2A endoleak. Quite often, a characteristic bidirectional waveform is seen in type 2A endoleak's entrance, meaning that there is only one point of communication with no outflow. So in this transverse view, we almost can see the path of the endoleak. And when using the flash mode, we can clearly see the entrance of the endoleak from the posterior aspect. In this case, there is an entrance and an exit demonstrated by this image, suggestive of a type 2B endoleak. So please note the high concentration of contrast at the entrance site in the posterior aspect branch, which will then disperse and exit through the IMA with much lower concentration of contrast. So now we have a transverse view with contrast seen surrounding the EVAR limbs at the center of the suck. The flash mode reveals a type 3 endoleak from a defect in the right limb. So here, as you can see in the graph, the remnant aneurysm sac continues growing. However, no obvious endoleak is visualized in the contrast scan, which can be suggestive of a type 5 endoleak, commonly referred as endotension. So contrast is an imaging modality equivalent or better than CTA for endoleak detection and classification. It also has the advantage of avoiding radiation and nephrotoxic contrast exposure. It can be used at bedside and in theater. It's cost effective, and however, it is operator dependent and requires training. Thank you for listening.
Thank you very much for that most interesting talk, João. Thank you, and for that novel use of contrast. So thank you. We'll have questions a bit later on.